Thank you very much, and good morning, everyone, particularly the midwives. I'd like to emphasize that I'm speaking on behalf of a large group of people who've been involved in the research which I shall be presenting as we go along. I work on the Eastern Cape of South Africa, which is on the Indian Ocean, roundabout where the S of South Africa is on the slide. This is in Dansani Township, where we assessed the diet of women and found that 50% of women, as in many poor countries, have less than 50% of the recommended daily allowance of calcium in their diets. And this is the entrance to our labour ward and our other hospital, Frere Hospital, showing that our midwives are kept very busy. And one of the commonest problems that we deal with is preeclampsia and eclampsia. So we are very highly motivated to try and find a solution to this fascinating condition. And one of the most fascinating aspects of this condition is the exceptionally large discrepancy in its occurrence in low-income countries such as ours and well-resourced countries. And there has to be some reason for this. And we don't yet know for sure, but one of the possibilities is that it might be dietary. I'm going to talk briefly about vitamin D and then concentrate on calcium. So for vitamin D, there are some observational studies suggesting that where there are low vitamin D dietary levels or evidence on blood tests, women are more likely to have preeclampsia. There's a systematic review which really has inadequate evidence to determine whether vitamin D supplementation does or doesn't reduce the risk of preeclampsia. There is one large ongoing trial which we had hoped would have been ready for presentation at this meeting. It's not yet ready, and I believe we should suspend our discussion of vitamin D until the results of this trial are available. So on to calcium. And in fact, the very first suggestion that preeclampsia may be a dietary problem came from Australia, from R.J. Hamlin, one of whose nieces is attending this meeting. And in 1948, he had the concept that preeclampsia was a dietary condition and initiated a program of dietary intervention in Melbourne. And you'll see from that graph that whereas they were having about 8 cases of eclampsia a year over the preceding 13 years, after the dietary intervention, which included calcium, the incidence of preeclampsia dropped to 0. 10 years later, working in Ethiopia, where he set up the famous fistula hospital with his wife Catherine, he noticed that preeclampsia was unusually uncommon, and again wondered whether this might be due to the diet, which had a lot of teff in it, which was high in calcium as well as other nutrients. 20 years later, Jose Belezan noticed in Guatemala a very similar thing, very little preeclampsia, and women with a diet high in calcium, and asked the question again, could this be a dietary problem? So in 1998, we conducted a systematic review of a number of small trials which had been conducted in which women had been supplemented with either calcium or placebo. And sorry, let's just go back to that, if I can. Doesn't matter, I won't go back. And the findings of that systematic review was that a large number of small trials showed a dramatic effect of calcium in reducing preeclampsia, but the one very large trial, the CPEP trial from North America, showed no effect. And the question was this simply a case of publication bias, or was there a difference in the communities, the North America one possibly not being deficient in calcium? And for this reason, together with our colleagues at WHO, we set up a large randomized trial in communities with demonstrated low calcium intake of supplementation with 1.5 grams of calcium compared with placebo. And the results of that trial have been incorporated into the systematic review. Now, I want you to just look at the graph on the right of this slide. The top section is in communities with adequate calcium in the diet and show no significant effect of calcium supplementation in the second half of pregnancy on the incidence of preeclampsia. Remember, in most of these Cochrane-type reviews, a reduction in the problem is shown by something to the left of the vertical line, and if the entire 95% confidence interval is to the left of the line, that indicates significance at the 5% level. If you look at the central part in which most of the trials are, you should be able to see that in the small trials, there are dramatic effects, large reductions in preeclampsia with calcium supplementation. But in the two largest trials, and the smallest little dot there is the WHO trial, the difference was not statistically significant. So although when one mechanistically puts together all these trials, we get a very striking effect, we do need to be a little bit critical of this and ask whether this may be a reflection of publication bias. And I feel we should take the most conservative interpretation and really concentrate on the very big trials, in particular the WHO trial, which gives us the most conservative estimate of the effect of calcium. So, and in that trial, the reduction was not significantly different in terms of the diagnosis of preeclampsia. However, the diagnosis of preeclampsia is not the most important thing. What is important is what happens to the women. And we can see when we look, the other thing which tends to suggest that the impact is not so much on the process of preeclampsia is the fact that in the WHO trial, calcium supplementation had no effect on proteinuria as an individual measurement, absolutely none. However, when we look at the important outcomes such as eclampsia, there was a trend towards reduction in eclampsia in these trials. When we look at maternal death, in the placebo group there were 7 maternal deaths, in the calcium group only 1. So this represented an 80% reduction. It was not quite statistically significant, but a strong trend to reduction in maternal death. And when we looked at the combined outcome of maternal death or severe morbidity, which included eclampsia, renal failure, admission to ICU, the important things that we really worry about, there was a significant 20% reduction in these severe outcomes of preeclampsia. So if we summarize the evidence, we see, first of all, epidemiological evidence of a striking difference in preeclampsia, eclampsia in populations who have high calcium and those who have deficient calcium. Calcium supplementation in the second half of pregnancy may reduce preeclampsia, but I don't think we can say with certainty that it does. But it certainly reduces the severe morbidity associated with preeclampsia by about 20%, and this alone is sufficient justification for paying attention to calcium in pregnant women. Ongoing research is important, and currently we are particularly interested in the concept of whether possibly supplementation in pregnancy is too late to affect the incidence of the preeclamptic process, which we know has its origins in placentation in the first trimester of pregnancy. And so we are currently collaborating with WHO on another trial, the calcium and preeclampsia trial. And in this trial, we are studying the effect of modest supplementation with 500 grams of calcium compared with placebo commencing before pregnancy. The participants of women at high risk who have previously given birth with preeclampsia and who intend to have another baby. And they are supplemented from before pregnancy up to mid-pregnancy. In the second half, all women will receive routine supplementation because of the preceding evidence. If this is found to be an effective intervention, of course we will need to look at the possibility or the need for population-level supplementation with calcium. The other research questions that are open, as I've mentioned, are vitamin D supplementation and the ideal dose of calcium. Unfortunately, all the trials that have been, or all the main trials have looked at very big doses, 1.5 or 2 grams, and there's absolutely nothing to indicate that one needs such a big dose, because the average difference in calcium intake between women in well-resourced and in poor countries is about 500 milligrams. So we don't have that evidence, but it may well be that the dose required is much smaller. So it's important to remember that calcium is not only important for pregnant women. We know that in the general population, calcium reduces hypertension, and certainly where I work, hypertension is an enormous problem. There's a reduction in osteoporosis, there's a reduction in urinary stones, there's an improvement in diabetic management, possibly a reduction in colorectal cancer. One recent finding in elderly women receiving very big doses of calcium was a possible increase in myocardial infarction. So we should always follow the principle that if something's good, more of it is not necessarily better. The other thing is that the tablets are not cheap. In South Africa, the cheapest we can get, if we're giving 1.5 grams, is about $1 a month for supplementation. Of course, if we used 500 grams, $1 would last for 3 months. But it's still not cheap, and they're very heavy. If you have to lug boxes of calcium around, calcium is calcium. It's very heavy to cart and to transport. So it's easy to say supplement everyone, but the practical implications are large. So what are the options for calcium supplementation programs? The first option would be individually to supplement pregnant women, which has the big disadvantage that reaches only women who are attending for antenatal care, and probably most women who really need it are not attending antenatal care. But if we take this line, we could supplement all pregnant women, or those individuals or those communities who have demonstrated low calcium in their diet, or we could limit it to supplementation of women at high risk of preeclampsia. And as I've mentioned, if there are sort of cost-benefit issues, we might consider lower dosages than the WHO recommendation. Remember, the WHO recommendation is constrained by the evidence, and the evidence, unfortunately, is limited to 1.5 grams or more. There's no evidence on smaller dosages. The next possibility is population supplementation with food fortification of staple diets. And we know that food fortification in public health in general have been some of the most effective public health interventions, and it is certainly feasible to supplement staple diets with calcium. This will reach most people in a poor community except those who grow their own food. And the final word, and perhaps the most important of this, is that one thing that we can start with immediately is health education on the importance of calcium in the diet. And this is where everyone, at whatever level they work, can find out which foods in the local community contain calcium. We know there's calcium in potato skin. There's calcium in all sorts of unexpected places. And we can encourage pregnant women and the population at large to ensure that they do everything that they can to consume a diet which is adequate in calcium. Thank you very much.